So I'm going to just first define some terms that you'll be hearing, and one of them is the medical term of papule. A papule is a bump, more or less than 5 millimeters. Some people use it to be cut off at 10 millimeters, but for this purpose we'll talk 5 millimeters. And then as the papules grow together or coalesce, they form what are called plaques, which are lesions that are raised up over the surface of the skin. They're not flat like what we call macules. And then in more advanced stages of PXE, the skin becomes lax and forms loose folds. So you can see any combination of laxity, papules, and plaques in the skin. And I'll show you some examples in a few minutes. So the skin is the earliest and the most visible manifestation for most individuals with PXE. And interestingly, I'll talk to you when I talk about PXE and women's health, this is especially true in females. Females tend to present with skin findings more frequently than males, who tend to present more frequently with eye findings. The earliest involvement tends to be on the neck, and then what's called the axilla or underarm. And these are the areas that are most frequently affected in PXE. There are other areas of involvement, including what's called the antecubital fossa, that's the crease in front of your elbow, and then what's called the popliteal fossa, which is the crease behind your knee, and the groin, and then the periumbilical, or the skin around the belly button occasionally, and the upper chest occasionally. And periodically we'll find it in odd places as well, like on the abdomen, but I'll show you some examples of that. So the papules are oval or irregular or rhomboid in shape. The disease was named pseudoxanthoma elasticum because xanthomas are cholesterol deposits in skin. They tend to have a yellowish color, and these lesions sort of mimicked xanthomas when they were first described, and it was found when they were biopsied that they did not contain cholesterol or fats, so they're called pseudoxanthomas. They look like xanthomas. In other words, they walk like a duck, but they don't quack like a duck. And the skin itself may have an unwashed or cobblestone look. I'm sure some of you, when you were first presented, were thought to have a dirty appearing neck, but you couldn't wash it off. That's a common story we hear in patients who present with PXE, or present with neck findings. So this is an example of somebody, and the arrow points to some of the papules and plaques. Maybe I'm not sure how easy it is to see from there, especially because can't really darken the room. Here's a more advanced example of a young woman with papules and plaques the back of the neck. And here's a more extreme example. This patient has primarily laxity and loose folds on the neck and also in the underarm. You'll see her underarm later on. And this is a more extreme form of laxity. It almost, in a sense, if you don't look closely, you can easily miss the yellowish lesions, some of which are actually flat or macular, some which are papular. This is the underarm. Here again you see papules. These are the two places we look most frequently. Here's another patient with plaques in the underarm and some papules. So the arrow on the right points to the plaques, the arrow on the left points to some papules or smaller lesions. And this is an example of extreme laxity of the underarm skin, similar to what you saw on the neck, same patient actually. Again, if you look closely, you can kind of appreciate there's yellowish changes in the skin, in the what's called the anterior axillary fold, the skin that's sort of in front there. This patient actually had a linear patch of pseudoxanthomas in the abdomen. This is an example of the antecubital fossa, or the crease in front of the elbow. You don't usually see it. Usually the findings here are very subtle. Now, the mucous membranes are very much like skin. If you biopsy them, the only difference between the mucous membrane and skin, or the major difference you see, is that they lack what's called a horny layer, well-defined granular layer that makes the horny layer. That's the surface of the skin that provides barrier function, so that when you put something on the oral mucosa, it absorbs very quickly because it doesn't have this horny layer as a barrier. And so things that affect the skin, like there are skin diseases like lichen planus, PXE, and so on, that not only affect the skin, but you can see the findings in the oral mucosa. This is an example of you flip your lip inside out, you might actually appreciate these findings in your own lip. They're actually pseudoxanthomas in the lip mucosa. Years ago, I have to remember, it was 1980, patient meeting, 82, or whatever, I can't remember when Mark's daughter was a senior in high school, but she, or junior in high school, but she did a lot of the work analyzing the photographs that we took at one of the meetings. Mark had very astutely noticed that many patients with PXE had these oblique folds in their chin. And actually we see these in people who are older and have a lot of sun damage, and what Jessica aptly described as old lady skin. But we found that in PXE we were seeing in patients that were much younger, and you'd see a high frequency of this at ages which you would never normally see this. But it's not due to actually PXE in the skin. You don't find evidence of pseudoxanthomas in infected skin. So it's sort of an aging change in the skin that's somehow related to PXE, but you don't find the elastic tissue calcification in these areas. In fact, if you biopsy non-lesional skin in PXE without an electron microscope, which is a very high resolution, high magnification form of microscopy, you won't see the findings that you ordinarily see. You just see the lesional skin. So we can't just do blind biopsies. We have to really hone in on lesions. Sometimes if we're not really sure if somebody's got PXE, a blind biopsy, the neck might show very subtle early changes, but it's much better to actually have lesions. Another example of the chain increases in PXE. So most of you had a skin biopsy, so for those of you who don't know what a skin biopsy is, it involves using a small circular punch, like a little cookie cutter that takes a piece of skin, usually 3 or 4 millimeters, but you can get them in several different sizes. And it takes a small core of skin that actually has all 3 layers of the skin, the epidermis, what's underneath the dermis, and then the subcutaneous fat. And you can either leave it open, stuff it with something to stop the bleeding called gel foam, or you can suture it to minimize the size of the hole in the scar. And this is what we get. So the skin specimen is then placed in a piece of wax. It's hardened, and it's sliced like a turkey roll or corned beef at the deli. It's a fine slices and placed on a glass slide, and then it's incubated with various colors of stains that highlight different types of tissue. So unfortunately, the pointer is not working. So I'm going to. Oh, I guess the pointer is working. In that little square, you're going to see a high magnification of where the arrow is pointing in the dermis. The pathology and the abnormality in PXE is actually in the deeper parts of the dermis. And you can see in the square that these kind of clumped, what are called basophilic or staining darker purple or blue clumps of elastic tissue. Ordinarily, elastic tissue fibers are very fine. You would barely appreciate them in a normal skin biopsy. This is not stained to highlight elastic tissue, but in PXE, the tissues are particularly abnormal. And here's an example of elastic tissue stain where you can see it again in the deeper parts of the dermis, and in the square you get a better picture of these little curled up, thickened elastic fibers. And this is what's called the alizarin red stain. It's similar to the Boncossa stain, in that it highlights calcium. And very striking here, you can appreciate the heavy calcification, which is confined to the elastic fibers in the lower to mid dermis. And this is an example we call a Boncossa stain, where instead of looking bright red, it looks black, but it's the same picture. Ordinarily, this would be negative in a normal skin. You would not see calcium deposits in the elastic fibers. So, question people always ask, well, what can you do about PXE skin changes? How can I make them look better? Well, one way is plastic surgery. And this is a photograph. I just took this out of a journal. It's not one of my own patients. It's a patient in South Africa, I think, who underwent tightening of the neck skin. A somewhat different approach. One of the nice things about sun-damaged black skin is that it tends to hide scars better than normal skin. The one thing you do better as you get older is you heal nicer. Scars particularly we see a lot with skin cancer surgery and patients with a lot of sun damage can remove large skin cancers and moved a lot of skin around, and yet it looks really, within a few months, you can barely even see where it was. So this is an example of somebody who had surgery to remove a swath of skin from the neck and then tighten the neck skin. But one of the things that happens after any type of surgery is eventually the skin loosens again, and the underlying disease is not really corrected, whether it be age or sun damage, or in this case PXE. And the other thing is it doesn't really change the cobblestoning or the changes to the dermis. In this case, you remove abnormal skin, but it doesn't prevent the rest of the skin from getting this abnormality. There are other, so skin, so there are other diseases that look exactly like PXE, and I think probably once or twice a year I have a patient referred to me from PXE International to examine, because the question of PXE is not really clear, and you get the biopsy slides and it doesn't look at all like PXE, and the skin looks pretty normal actually. Fortunately, our department has expertise in this disorder. We have a pathologist who's very astute in diagnosing this, and published on it. It's a condition that's called, well, it's used to go in the white fibrous papulosis of the neck, or papillary dermal elastolysis, meaning that this elastic tissue is dissolved in a very upper portion of the dermis. They now lump together something called fibroelastolytic papulosis. It looks exactly like PXE. I mean, really, the things that tip us off to this is that, number one, the patients who have this disease present when they're older. They present when they're 50, 60, 70. They don't present when they're children or when they're young adults. Number two, they have no eye findings. Everybody with PXE at this age is going to have something abnormal picked up on an eye exam, whether their vision is abnormal or normal. These patients are usually very relieved to find out they don't have PXE. That usually is followed by a nice check to PXE International. So again, talking about how plastic surgery works in PXE, one of the things that's sometimes done in plastic surgery, and I'll give you an example, it's called abdominoplasty, when patients have bariatric or weight loss surgery. They often lose a tremendous amount of weight, and then the skin hangs down like a loose blanket almost. And not unlike, I could exaggerate it, but not unlike the skin abnormalities in the groin sometimes, or the other arm of patients with PXE. So what is done is that it's a bit like making a bed in a hotel, or at home. They pull the skin as tight as possible, remove the excess, and then place the scar in an inconspicuous location, like under the breast, or in the case of a facelift, behind the ears. So you tighten this, you pull the skin as tight as you can, or as tight as practical, and then you remove the excess skin and where you want to place the scar, and then try to put the scar in a place where it doesn't really show. And it's been found that, at least in fibroelastic papulosis, and in some cases of PXE, that there are laser techniques called fractional CO2 laser, or something called Fraxel, to improve the surface appearance of the skin. It's not going to change the underlying disease. It may provide temporary improvement. Can be touched up later on, especially as the technology improves. What it really does is it puts another layer of collagen or scar tissue between the epidermis and the abnormal dermal skin, and it can really it doesn't make the skin look perfectly normal, but it can make it look better. So sometimes a combined approach of plastic surgery and fractional CO2 laser, particularly with somebody who's done it before and is familiar with PXE skin, may lead to a significant improvement. So, there is hope. I mean, everything can be cured by throwing money at it. And as we do try to provide some help through PXE International, patients dealing with their insurance companies, but it's sometimes it's fruitless, sometimes it works. It just depends on their view of this as a cosmetic issue versus a true disorder, skin disease. Again, we have to, all patients undergoing anesthesia with PXE should have some sort of pre-op cardiac evaluation. Smoking impairs wound healing, and plastic surgeons generally try to avoid doing cosmetic procedures in active smokers. That's just something that you should be aware of. And although it improves the appearance of lax skin, it has no effect on the underlying process or normal aging, and eventually laxity is going to recur, and some of the sort of cobblestoning or papular abnormalities are going to recur or worsen with time. It's going to have to be repeated. In general, this question comes up is, how well does the skin in PXE heal? Skin in PXE seems to heal as well as skin in normal patients, unless it's occasionally will discharge calcium afterwards, but that's not very common. And about 75% of patients who undergo plastic surgery are satisfied with the outcome, which is not to say that the outcome is unsatisfactory in the rest, but expectations differ between patients. So I'm going to just move on to the next talk, and then I can maybe entertain a few questions, or we can certainly entertain a lot more questions this afternoon. So when I say sex in PXE, I want you to understand I'm talking about the sex of the patient. I'm not talking about sex in the city. I realized that right, because I had to qualify that. We're going to talk about oral contraceptives, pregnancy in PXE, hormone replacement therapy in PXE. I'm going to hit people of different age groups here. And then calcium and PXE, mammography and PXE. So sex in PXE is, again, as I said, dealing with the issue of sex in the individual and how it affects PXE. Most published studies have shown that there's a preponderance of females, usually in a ratio of about 2 to 1. But as Yoni showed you, this is not on a sex chromosome. The gene is on what we call autosomal, and it should occur equally in frequency between males and females. And I can talk to you give you a lot of reasons why there's difference may occur, but I'll just summarize a few of them. When we look at very young children in our pediatric studies, the ratio is about 1 to 1. So the difference seems to become more obvious as people get older. The PXE International Registry is approximately 70% female, and we've even looked at that, and I'll tell you more in a second. So when I say among children, the ratio is 1 to 1. Among kids, they all present with skin finding. We're not diagnosing young children very rarely with cardiovascular disease, and pretty well never by an eye exam. And as I said, the reason for the discrepancy is not clear. We even looked at, so we did a survey of people who had PXE, and we asked them what their siblings had. I figured, well, there may be a situation where women are much more likely to engage with patient support groups, and that's true. I mean, women are, guys are macho, they're not going to, join a community, whereas women tend to do that. So we asked people what their siblings, figuring that would certainly have no bearing. It should be equal among the siblings of females and males, but even when we did that, we found that it was primarily 60 to 70% female. So we don't know what the reason is. Could it be a difference in modifier genes, or the expression of the gene based on other modifying factors, something related to the environment or epigenetics, or something related to higher phosphate levels, which I think we'll be talking about during the research meetings later, or research talk later on. So it remains an interesting and so far unexplained phenomenon. Yes, well, this is actually pretty true. There are some, that's right, so that explains it. The male and female brain. So females tend to develop, and we've done studies, and they've shown that females tend to develop visible signs at an earlier age, probably because their presenting sign is most likely to be cutaneous or skin. Despite this, the mean age of diagnosis is similar. There seems to be a longer latency for males because they don't tend to have symptoms as early, because they don't tend to present with skin findings as early. Females are more often diagnosed by dermatologists, and males are more often diagnosed by eye specialists than females. And unfortunately, I apologize for those of you who have difficulty with vision, but I wanted, the purpose of the slide is to show you no matter where on the skin you're looking, whether it be the neck, the underarm, the antecubital fossa, whatever, there's a significant difference in the reported, between what females report and what males report. In every single instance, females have a significantly higher incidence of involvement in each of these areas. In general, women tend to have more with normal best corrected visual acuity. I know that's no consolation to those of you who are female and have significant retinal bleeding and have lost central vision. But there's a much higher incidence of this in males. Now, it's interesting that when we did our surveys, we found a significantly larger portion of females had received injections of vascular endothelial growth factor inhibitors like Avastin, Eylea, Lucentis. And we think that's because women tend to have later onset of bleeding, and so and these treatments were not widely used until 10, 12, 13 years ago, and so that more as women developed retinal bleeding at a later age, they're more likely to be able to avail themselves. As time goes on, this difference will disappear because basically you're going to be dealing with a smaller cohort of the very elderly, and more people will have the opportunity to receive these treatments, which are really, as Wayne will tell you, completely alter the landscape of visual disability and PXE, and prognosis with PXE. Males with PXE are significantly more likely than females to have angina or to have had bypass surgery or stents. They have higher cardiac phenodex, which is more severe, higher scores of the cardiac abnormalities. In general, males over 30 tend to have a higher BMI and we're likelier to have hyperlipidemia than females. But it's interesting, that only in females was there a significant association of angina with hyperlipidemia. The others seem to be independent risk factors. So clearly PXE has something to do, has something to contribute that actually is at least the influence of PXE may be such that the incidence of that the effect of the risk factor of hyperlipidemia may actually be just overwhelmed by that and not be as obvious.
What is hyperlipidemia?
What is hyperlipidemia?
Hyperlipidemia means high lipids or high cholesterol, high triglycerides. So when we talk about hyperlipidemia, at least in terms of cardiac, we usually mean high cholesterol levels. But this encompasses both types of lipids and fats.
5-minute warning.
Pardon me?
5-minute warning.
5-minute warning?
Yeah.
Wait a minute, you don't need 5-minute warning.
We took 30 minutes, you're at 25 minutes, so I'll give you
Why give them 2 talks? All right.
The men can
Okay,
leave the
so
room.
there wasn't a significant difference in peripheral vascular disease between males and females over 30 years of age. I feel like this was like we're back at the hearings on Thursday.
Well, take your time, we'll just go and get some breakouts this afternoon.
All right, I'm just going to move on. There is no significant difference in risk of gastric bleeding between males and females. So hormonal contraceptives and PXE, we're talking about birth control pills. As you know, birth control pills are generally a combination of a synthetic estrogen and a synthetic progestin. The new oral contraceptives have very low doses of estrogen. There are other things besides oral contraceptives. There are NuvaRings rings, and there are other ways of giving contraceptives. Yes?
Can we get these slides later?
Yeah.
This is all being recorded and it'll be on the internet.
Yeah, they're available. Free.
And we already have this talk also on the Internet Archive, so yes. And there'll be time in the breakouts to ask a lot of questions. Great, perfect.
This is why the Democrats couldn't get their questions in. There is actually no published data on oral contraceptives in PXE, but there's no evidence to date of an adverse effect of oral contraceptives on PXE, although the numbers in our survey were pretty small. But so far there's nothing to indicate there's an issue. That's not to say that they should be just used with impunity. We already have guidelines for who should avoid them: people with cardiovascular disease, a history of hypertension, smokers over the age of 35, those with a history of deep vein thrombosis, and that's not altered by a diagnosis of PXE. And in general, we prefer to use low estrogen oral contraceptive. It reduces the risk of clotting. And then if estrogen is contraindicated, there are other forms of contraception. There are progesterone-only contraceptions, for example, Norplant. There's an oral one as well. So moving on to pregnancy and PXE. One of the really things I'm personally most proud of from the surveys we did back in the 90s and still do is that we were able to really get a handle on the effects of PXE on pregnancy. We had something like 750 pregnancies. I think the previous largest study had less than 40. And we were really able to do a rigorous study. We found that 83% of the pregnancies ended in live births, and 1% stillbirths, and I think the remainder were miscarriages. And that's exactly the incidence in the normal population, unaffected population. 12% of women reported worsening of skin during pregnancy. There was a 10% incidence of pregnancy-related hypertension or gestational hypertension, which is within the normal range. We found gastric bleeding and retinal complications of less than 1%. Previously, the books have said that this was that gastric bleeding in pregnancy was a particularly common phenomenon. And 76% of the pregnancies were completely uncomplicated. And we found that it didn't matter how many times you were pregnant or whether you'd ever been pregnant or hadn't been pregnant, with the eventual clinical severity of skin, eye, or cardiovascular manifestations as you aged afterwards. So it didn't seem to have any further effect, which is particularly significant because 70% of women at that time, maybe now that we've got these studies, the number has gone down significantly, but they were advised against becoming pregnant by their healthcare professional and didn't get pregnant for that reason. And about 11% didn't get pregnant because they feared an adverse outcome, either in their pregnancy or they thought their disease might get worse. So this is very encouraging information. There's no evidence that PXE is associated with a markedly increased incidence of fetal loss and adverse pregnancy outcomes. And although gastric bleeding is higher than the general population, it's much lower than what had been previously reported. And retinal complications are uncommon in pregnancy. So I think we're looking around I think that we should really talk about hormone replacement therapy because the age group of the audience certainly would have an interest in this. As you know, hormone replacement is really, the recommendations have changed dramatically in the last 10 plus years, since the Women's Health Initiative study was published. As you know, hormone replacement therapy includes estrogen and progestin. If you've got a uterus, you take progesterone in addition to estrogen to prevent uterine cancer. If you don't have a uterus, you don't need to take the progesterone. It was found that, well, the bottom line in PXE is that we don't know that HRT has a specific effect on PXE or that PXE patients are necessarily more of an issue, more of a risk. But those who have other risk factors should not be treating them with hormone replacement therapy. We have treatments for high cholesterol, we have treatments for hypertension, we have treatments for established heart disease and osteoporosis and so forth. And that's really the route to go. The current feeling is that hormone replacement therapy should be short-term for control of menopausal symptoms. What the study showed was that if you went, from 50 to 60, 60 to 70, and over the age of 70, that in the 50 to 60 age group, there wasn't that much of an increase in cardiovascular mortality or breast cancer, but as you got to the older groups, the incidence of breast cancer and cardiovascular mortality increased significantly, particularly over the age of 70, so that prolonged use of HRT is really discouraged, and it's recommended if it's going to be used for just a couple of years to get people over the worst of the menopausal symptoms and then taper rapidly. PXE should be considered a risk factor because there's a 10-year risk of over 20% for stroke, peripheral vascular disease, and coronary disease. So I think that alone would mandate aggressive treatment of risk factors and avoidance of hormone replacement therapy. I'm going to skip over calcium magnesium. I think that Mark is going to talk about that about the magnesium trials. I will say that I don't recommend calcium restriction that leads to osteoporosis. Calcium levels are very tightly regulated in the body and really don't have a whole lot to do with PXE, and there's really no particular benefit to restricting calcium. There's no particular, the harms outweigh the benefits. I won't talk about pyrophosphate because that's going to be talked about later on as well in the research talks. Another thing that we were able to do, thanks to the PXE International, was to do mammograms in Yeah, I love that cartoon. Yes, I did have my mammogram today. Why do that? We were able to study mammograms in PXE. A lot of women who had PXE were undergoing mammography and having breast biopsies afterwards because of calcifications in the breast. There are specific types of calcifications that occur in breast cancer that differ from PXE. The calcifications in PXE are generally either in vessels or in elastic tissue in the skin, and we were able to, and a good mammographer will know the difference. We showed there is a significant increased incidence of microcalcifications and vascular calcification, just as there would be in the normal population, but the higher number of these, and that there was an increased incidence of skin thickening in the underarm. And we actually found a few women who had, we could actually look at the underarm and see the calcifications in the underarm skin, those little white dots in that thickened area there. But that's a pretty specific finding, and you don't need a mammogram to show that, except that if you see that in a mammogram, it should alert you to the fact that this is probably nothing to do with breast disease. We found no increase in breast cancer risk in PXE. From our surveys, that the only specific finding was it was thickened axillary skin with microcalcifications. That means specific for PXE. The other finding is if you found skin thickening, skin calcifications, and breast calcifications or vascular calcification, this would suggest the possibility of PXE, but the specific type of calcification was very helpful. The little spicular-like calcifications you see in breast cancer are not those that you see in the normal PXE. We actually found one patient who did have breast cancer that had been missed in the original mammogram. The trees were obscuring, or the forest wasn't seen for the trees, so to speak, that all the calcifications kind of obscured the breast cancer. The mammographer picked it up, and so mammography can be very helpful, but it can be also very confusing at times. So all I have to say. Senator Graham?